Sorry about that. Thanks, Rana. Thanks. Appreciate it.
Good afternoon, everyone. Hopefully you can hear me okay. My name is Adanma, Ayanambakkam for the record, but I'm one of the GU-Med-Oncs at the University of Oklahoma, and it's my honor and privilege to be here and welcoming this group. I'd like to invite all the speakers to come up on stage. For the session today, we'll be splitting it into two parts. The first three sessions followed by a 20-minute Q&A session, and then the last three speakers followed by another Q&A. Thank you, and for the first talk, I'd like to invite Dr. Wenzin Zhu to talk about baseline and early on-treatment plasma KIM-1 levels associated with outcomes in RCC. Thank you.
Hi, good afternoon. Thank you to Adanma and to Rana and to the scientific committee on behalf of my co-authors for the opportunity to speak on baseline plasma KIM-1 and association with outcomes in RCC. And I'm Vincent Hsu from Dana-Farber Cancer Institute. These are my disclosures. The background is that KIM-1, as you've nicely heard already, is a transmembrane protein overexpressed in RCC, including clear cell RCC. And it's a circulating biomarker that is emerging for early detection of disease, risk stratification after nephrectomy and adjuvant therapy, which you've just heard about, as well as disease recurrence and treatment monitoring. In Checkmate 214, a reduction from baseline in circulating KIM-1 levels was previously associated with long-term efficacy of immunotherapy with ipi/nivo, but treatment with sunitinib, the change in KIM-1 levels at 3 weeks was not predictive. COSMIC 313 was a randomized phase 3 trial comparing treatment with cabozantinib, ipilimumab, and nivolumab versus ipilimumab and nivolumab. In COSMIC 313, as previously reported, progression-free survival was superior in the triplet arm, but overall survival was similar between the two arms. In this study, we evaluated the relationship between KIM-1 levels and clinical outcomes in COSMIC 313 in this post-hoc biomarker analyses, and also correlated with other biomarkers. COSMIC 313, as known very well to this group, is a randomized phase 3 trial where patients were assigned to either ipilimumab plus nivolumab plus cabozantinib or ipilimumab plus nivolumab plus placebo. Plasma samples were evaluated at baseline and every 3 to 4 weeks and collected for biomarker analysis. KIM-1 levels in this study were evaluated using a mesoscale discovery-based electrochemiluminescence assay. This is the same assay platform used in Checkmate 214, and as you've just heard, Rampart, as well as iMotion 10 and other studies. Higher baseline KIM-1 levels were associated with worse IMDC risk. As you can see in this trial where all patients were IMDC intermediate or poor risk, worse IMDC risk was associated with higher KIM-1. Patients who had prior nephrectomy had lower KIM-1. Both of these results are consistent with prior studies, including Checkmate 214, Javelin Renal 101, and others. Higher baseline KIM-1 levels were associated with greater disease burden. At baseline, KIM-1 high was associated with a greater sum of lesion diameters, and this correlation remained the same at week 10, with the correlation coefficient similar at the 2 time points at 0.58. This shows that dynamic changes in KIM-1 also reflect dynamic changes in the tumor burden. Baseline KIM-1 levels are strongly prognostic for overall survival, again consistent with prior studies. The median KIM-1 level in COSMIC 313 was 1,227 picograms per mil, around double the median level seen in Checkmate 214, reflecting the higher clinical risk of this patient population. Overall survival was worse for KIM-1 high and better for KIM-1 low in both treatment arms. We looked at correlation between KIM-1 levels and RNA signatures in this trial. Low baseline KIM-1 levels were associated with a more hypoxic, more angiogenic, and more stroma-enriched tumor microenvironment. Conversely, high circulating KIM-1 was associated with greater M2 macrophage activation. Looking at the predictive signal, KIM-1 levels were not predictive of differential response to one treatment arm versus the other. In other words, the objective response rate and the progression-free survival were similar among both treatment arms regardless of your baseline KIM-1. This is again consistent with prior studies showing that baseline levels of KIM-1 don't enrich necessarily for response to IO versus TKI versus combinations. However, baseline KIM-1 levels were strongly prognostic even when adjusting for other clinical variables. And so in this forest plot, you can see common clinical variables associated with prognosis, and baseline KIM-1 remained strongly prognostic for survival after adjustment for IMDC, prior nephrectomy, sarcomatoid features, tumor burden, and these other clinical variables shown here. These findings suggest that baseline KIM-1 might be a useful addition to patient prognostication if available. We also looked at the combination of baseline KIM-1 with angiogenic transcriptomic signatures. And as previously noted, patients with higher circulating baseline KIM-1 tended to have less hypoxic and less angiogenic tumor microenvironments. Nonetheless, these two findings, the angiogenesis score and baseline KIM-1, still remained independently prognostic, even when adjusting for each other and these other variables. Shown in a graphical format, baseline KIM-1 levels and angiogenesis scores were independently associated with overall survival and contribute complementary biology to our understanding of the tumor. In summary, baseline KIM-1 is a strong, independent prognostic marker for overall survival, and as shown in COSMIC 313 and previously reported in Checkmate 214, early decreases in KIM-1 on immunotherapy have been associated with better outcomes. Baseline KIM-1 is not associated with objective response rates to cabo-ipi-nivo or ipi-nivo, showing that this is a prognostic baseline biomarker, not a predictive one. The prognostication of KIM-1 is independent after adjustment for IMDC risk and hallmark angiogenesis signatures, showing complementary biology. Integration of these biomarkers may further ameliorate our ability to kind of detect the high versus low risk patients. These findings are an ad hoc analysis and require prospective validation. I would like to thank the patients, the families, and the study teams and staff involved in COSMIC 313, as well as Exelixis, who sponsored this biomarker analysis. And thank you for your attention.
Wonderful. Our next speaker is Nicholas Salagia from Roswell Park Comprehensive Cancer Center, speaking on stereotactic body radiation therapy that enriches mediators of humoral immune activity in metastatic RCC.
Thank you, Dr. McKay. Hi, everybody. So much to the chagrin of my PI, Jason Muhich, we've kind of evolved at Roswell Park into a B-cell biology lab in the context of metastatic RCC, and I'll show you why and how we might be able to leverage some of that for improving immunotherapy sensitivities. So obviously immunotherapy has been a revolution for patients. That's no surprise to anyone in the room. But even in the most controlled settings of phase 3 clinical trials, we're still peaking at about a 60% objective response rate with ICB or ICI-based combination therapies. And so really what we're trying to understand is there a way we can reshape the tumor intrinsic microenvironment to actually improve the likelihood of immunotherapy successes? And in order to do that, we really need to understand what's underlying the immunotherapy sensitivity of select microenvironments in kidney cancer. And our group, as well as a number of others in this room, have kind of coalesced on this idea that humoral immunity and surrogates of humoral immunity, like tertiary lymphoid structures, are consistently associated with checkpoint blockade responsiveness, both in kidney cancer and other solid tumors like melanoma. It turns out, though, it's not just general humoral immunity or B-cell infiltration that has a predictive role in immunotherapy responsiveness, but it's really the maturation and eventual effector function of these B-cells that portend improved outcomes with checkpoint blockade. This is deconvolution data from Emotion 151, patients receiving either atezolizumab, bevacizumab, or sunitinib. And you can see that while B cells in general are associated with an objective response compared to not objective responses, it's really driven by these memory and class-switched memory B cells, these more mature effector-like populations. And even when you compare the responders to the atezo-bev arm versus in the sunitinib arm, we're seeing that same significance hold true. This is also consistent with other groups' work. This is a paper from Wolf Friedman's group, Maxime Malin, back in Immunity in 2020, showing that patients who had high intratumoral IgG binding to tumor cells had prolonged PFS to either nivolumab or nivolumab ipilimumab. So how can we leverage this information to ultimately reshape the tumor microenvironment to improve B-cell responses, B-cell maturation, and effector function in hopes of improving immunotherapy sensitivity? And our group at Roswell Park over the last 10 years or so has leveraged unique access to a clinical trial wherein patients with metastatic renal cell carcinoma were treated with 15-gray SBRT to the primary tumor and then underwent cytoreductive nephrectomy 4 weeks later. We have all these tumor suspensions or tumor digests stored down as single-cell suspensions and cryopreserved for functional and immunophenotyping assays. And our groups previously showed not only an increase in tumor antigen expression, increase in proliferating cytotoxic T cells, and increased TCR clonality, but we've also shown increased predicted interferon and TNF-dependent tumor immune interactions in the microenvironment following SBRT compared to non-irradiated controls. But what we haven't looked at yet is actually the impact on the humoral immune compartment in these tumors. So using a subset of these patients who underwent bulk RNA sequencing and 8 clinical pathologically matched non-irradiated controls, we performed first deconvolution, and we can see not only an increase in the predicted B-cell infiltration scores, but importantly, an increase in the class-switched memory B-cell scores, which we use as a surrogate of this B-cell maturation, IgG class switching, and ultimately anti-tumor effector function. We also performed BCR repertoire reconstruction using the TRUST-4 pipeline, and albeit non-significantly, we do see a trend towards increased clonotypic diversity in the B-cell receptor sequences with SBRT compared to controlled tumors. This was really driven by this initial analysis that we performed with gene set enrichment here, where 10 of the top 20 or so pathways with a normalized enrichment score of 3 or higher favoring SBRT were associated with immunoglobulin production, BCR activation, and B-cell signaling in general. Congruent with this, we also saw significant enrichment of 2 different tertiary lymphoid structure scores, the imprint TLS from Wolf Friedman's group and the 12 chemokine score from Jim Malay's group. Our lab loves orthogonal validations, and so we also performed single-cell RNA sequencing on a subset of these tumors. Isolating the B cells, we show 2 distinct populations defined by their genotypic expression or their transcriptomic expression, a more plasma-like class-switched population, which is that small group on the right, and a more immature non-class-switched B cell population. And if you look at the relative abundances across these groups, you really see that that plasma or class-switched subgroup is enriched for sarcomatoid-derived cells compared to the more naive B cell-like phenotype being enriched for control-derived B cells. Differential expression analysis reinforces this, where we see a significant enrichment of Ig class switching, so IgG clonotypes or IgG transcriptomes with SBRT, and significant enrichment of the non-class switched isotype IgD in control tumors. At the protein expression level, we performed full spectrum flow cytometry on a total of 13 cases as well. This was done by Adil Khan, an exceptional staff scientist in our group. And using conventional gating strategies that we borrowed from Tulia Bruno's group down at the University of Pittsburgh, we showed that not only are control tumors significantly enriched for more of a naive B cell phenotype, these are IgD positive, CD38 negative B cells, but importantly, SBRT treated tumors are enriched for B cells that take on this antibody class switched and antibody producing phenotype that we defined as IgD negative, CD38 positive, with CD38 being a classic plasma cell marker. So what does this actually mean? This obviously is not in the context of concurrent immunotherapy, but we have a number of studies in this space that are investigating the idea of SBRT as an immune preconditioning agent prior to immune checkpoint blockade in either oligometastatic or diffusely metastatic disease. I do want to highlight the Samurai study, not just because Dr. McKay is one of the PIs of that project and lead in sitting up here on the stage, but because we think it uses a practical ablative dosing regimen. It takes the Fast Track 2 study of either 14 gray times 3s for 42 gray or a 26 gray and 1 fractionation pattern, and then resultantly gives adjuvant ICB following radioablation. We also have mechanistic work going on in a collaboration with the University of Rochester, Phil Rappold and Scott Gerber, using syngeneic mouse models and B-cell depletion to look at the impacts of SBRT and B-cell mediated immune surveillance in the context of kidney cancer. So with that, many people to thank at Roswell Park, of course, the members of the MUHITCH lab. I showed some preliminary data, not only from Adil Khan, but our former postdoc Jackie Chow, our clinical collaborators Tom Schwab and Anu Singh, our colleagues in immunology, informatics, and across upstate New York who have been great collaborators. And most importantly, thank you to the KCRP who's been a consistent funder of this work since its inception. Thank you.
Next up, we have Dr. Praful Ravi talking about anti-tumor activity of LU PSMA-617 in PSMA-positive metastatic clear cell RCC from his phase 2 trial laser. Thank you.
Thank you. Thank you, everyone, and thank you to the KCRS organizing committee for inviting me to present this abstract on behalf of all my co-authors. Here are my disclosures. So by way of background, we all know that there is a clear unmet need for new therapeutic targets in clear cell RCC. And PSMA, despite the name being prostate-specific membrane antigen, is actually present on the neovasculature of many solid tumors, particularly clear cell RCC, and this has actually been confirmed by both RNA-seq data and by IHC, and PSMA can also be imaged by PSMA PET. And here's the data showing that in small studies, meta-analysis saying that 80% of clear cell RCC lesions are seen on PET. So, and we have a drug for it. We have Pluvicto, lutetium PSMA-617. It's a proven drug in advanced metastatic prostate cancer, which is PSMA positive, and it's relatively well tolerated. So the aim of this trial is to evaluate the safety and activity of this drug in PSMA positive RCC. Here's the trial design, here's the schema. This was a single center IST, and it enrolled advanced clear cell RCC patients who'd received at least one prior TKI and one prior immunotherapy. They received 2 cycles of Pluvicto, and patients had to be eligible by PET scan. So I'll get into this on the next slide, but you needed to have at least one PSMA positive lesion and no or limited PSMA negative disease. And they could get 2 cycles, be imaged with an interim PET scan. If the target was still present, they would get up to 4 more cycles. And of course, we'd have response assessment with conventional imaging. And this trial was designed in a Simon two-stage design with early stopping for futility, where if we saw at least one response in the first 9 patients, we would enroll a further 15 for a total of 24 patients. The objective response rate was the primary endpoint, targeting an ORR of 25%, which is similar to belzutifan. So here's the eligibility. So I wanted to show this slide about how we selected patients. So the trial activated exactly a year ago, KCRS 2025. And at that time, we had eligibility with 1 PSMA positive lesion greater than liver and no negative lesions less than or equal to liver. This is similar to how vision criteria work for prostate cancer. And we screened 10 patients. Only 4 were eligible by PET scan, with 6 being ineligible, predominantly because of PSMA negative disease equal to liver, basically. So we were getting all these patients who were having some disease equal to liver, and we weren't treating them because of PSMA negative disease, and the screen fail rate was 60%. And of these 4, 3 received therapy with 1 deteriorating before starting trial. So given this screen fail rate, we amended the protocol in October to be a bit more permissive, basically. We still needed 1 PSMA positive lesion at least, greater than liver, And we allowed no or limited negative disease less than liver, up to 25%. And this is sort of a practical sort of assessment on a PET scan. This is how we treat, vision criteria, one thing, but in the clinic for prostate cancer, if a patient has 85% PSMA positive disease, we still treat that patient with Pluvicto because we're banking on that positive disease responding and overall the disease responding. And with the change, there was a much higher screen positivity rate. We screened a further 11 patients, and very few were ineligible. In fact, all were only ineligible because of lack of positive disease. The majority were eligible by PET scan, and all but one got treated. One had symptomatic progression, switching to standard of care instead. So all in all, 9 patients were treated in the stage 1. Here's the characteristics, pretty similar to what you'd expect for an advanced clear cell RCC cohort, median age of 73. I'd point to here, prior lines of therapy, median was 4, including one patient who had 13 prior lines of therapy. This is a patient who's had kidney cancer, I think, for 15 years. I think may well be Tony's patient. And most patients, you could see fair predominance of bone disease as well as liver disease. And here's the patient flow and treatment details. So 9 patients enrolled, 9 received therapy, 1 completed therapy per protocol, 4 had progression radiographically, and 4 clinically progressed. And you can see here the median number of cycles given was only 1. So 5 out of the 9 patients only had 1 cycle, 1 had all 6 cycles, limited in no dose delays or interruptions. 2 patients had dose modifications on account of baseline EGFR with standard dose reduction, as we do with prostate cancer, for example. So here's the response data, and you can kind of tell with only 9 patients treated that they didn't move to stage 2, so there were no complete or partial responses. Stable disease was seen in 2 patients. Progressive disease is best response in 3, and 4 patients were unevaluable because they all clinically progressed prior to radiographic evaluation. These were sick patients to some degree. So the response rate was 0. 1 patient with stable disease did have minor shrinkage, about 4%, but really this is sort of, we're grasping at straws here, I think. So here's the swimmer's plot, and you can see here the 2 patients on the top are the ones who had 4 and 6 cycles. Patient 1, the first patient enrolled, actually completed all 6 cycles and had stable disease. But then there are these 4 patients who rapidly progressed clinically, and you can see of these 2 or even 3 of them unfortunately died shortly after initiating therapy. So these were sick patients. The efficacy in terms of PFS and OS, it's rather moot here. The median follow-up is 3 months, median PFS of 2 months, and a 6-month OS rate of 62%. Treatment-related AEs, you can see the treatment is well tolerated. This is in line with what we expect from the drug, how we give it in prostate cancer at least. Dry mouth, grade 1 only in 4 patients, some fatigue a little bit more. I think the anorexia grade 2 here is probably more likely reflective of the disease rather than necessarily the treatment. So overall, well tolerated, easy to give. So in conclusion, lutetium PSMA 617 was well tolerated, but it had no single agent activity in these heavily pre-treated patients with PSMA positive metastatic clear cell RCC, albeit 9 patients, but 0 out of 9, we did not hit the threshold to continue enrollment. Now I'm speculating about reasons why this could be. Is it the target? First of all, PSMA is on the neovasculature. It's not on the tumor, so it's not, it's next to the tumor, but it's not on it. And we did allow PSMA negative disease, and as you saw, there were patients with a disease which was equal to liver at least who were enrolled, not the majority, but even with this, maybe there's some PSMA negative disease which contributes. The other possibility is it an engagement problem? The target's there, the drug binds, but is it engaging and sticking around to exert its effect? Because remember, this drug has to bind to the target, and then the radiation has to be emitted. If the drug is just being washed out because it's on the vessels, is it going to bind? And the real regret I have in this trial is we didn't integrate SPECT-CT at 24 hours to see, is the drug hanging around? And thirdly, could it just be a radio resistance or radiosensitivity issue? Is clear cell RCC inherently resistant to this type of therapy? So in my mind, future trials of our radiopharmaceutical therapy, which I still think has a role potentially to investigate, should really look at likely alternative targets and combination strategies. I'd like to acknowledge the support and collaboration here of nuclear medicine and GU oncology. Trials like this do not happen easily without close integration between the 2 disciplines, the research and the clinical teams. Funding from Moderators, who sponsored the trial in terms of providing funding and drug, and of course patients and their families who enroll. Thank you very much.
Thank you.
Thank you. We will now kick off a small, brief 20-minute Q&A on the first 3 talks. I think we have.
My question is for Nick, actually. So, mechanistically, what do you think the SBRT is doing to the tumors? Because that's going to really matter in terms of the trial design, right? So, if you think that it's triggering more antigen presentation versus impacting the inflammatory state of the tumor versus hypoxic state or metabolic state of the tumors, why do you think that the humoral immunity change is going to impact checkpoint blockade? How are you thinking about it from a mechanistic standpoint?
I can speak loud. Great question, first and foremost. The reviewer for the manuscript that we just submitted revisions for asked the same thing, so if that was you, thank
Not me. Not me. This happens to me a lot, but I'm never the reviewer.
I think there's a few different mechanisms at play here that go along with an entire pattern of upregulated immune registration in these tumors following radiation. The first, which I highlighted briefly in some of our initial work in this field, showed is an increase in tumor antigen expression. So we have shown by flow, both in cell lines and in patient samples, that SBRT induces TAAs like MIE-4, right? CA9, DAMPs, other mediators of immunogenic cell death like tau reticulin. So I think that's number one. I do think there's a tumor intrinsic mechanism there. Truthfully, I don't know if there's a tumor intrinsic hypoxia signaling response going on as well. It's not something we've ever looked into. I think that's a really interesting concept, though. And then number two would be antigen cross-presentation and immune priming. So we do see in our initial single cell analyses that we published, Jackie Chow was the first author in JIDC a couple of years ago. We do show in select immune populations that are probably more DC-like, probably monocyte-derived DC-like, we do see an increase in class 2 expression. We reiterated that analysis for the manuscript. Didn't show it today for the sake of time, but we do think that's part of a pleiotropic myeloid reprogramming system that occurs with radiation. We do think there are some immunosuppressive effects as well that we can talk about on the side. But one of the things we do see is an upregulation of antigen presentation machinery, antigen processing pathways. And then third, I think if we do see insight to these TLSs, I think there's a lot of evidence to support a T-cell B-cell crosstalk. So whether it's a TFH or an effector T-cell, I think both can be true. But if you look at work from people like Briscoe Palos in the last year or so, these in situ TFH B-cell interactions are actually necessary to ramp up anti-tumor immunity. Obviously, there's been some great TLS papers in our space, including one that just came out yesterday. If you haven't read it in Nature, Dr. Braun, Dr. Wu, many others that also start to get at this more T-cell focused side of the story. But in the context of humoral immunity, those are kind of the 3 mechanisms we're looking at as potentially involved in accelerating this humoral anti-tumor response.
Yeah, Vince, question here. So really interesting. I mean, it looks like at this point in time, clear signals time and time again of prognostic implications of KIM1. And as you try, and others in the previous talks today, to try to see some sort of interaction between immunotherapy, that doesn't look like it's very robust. So if that's not the case, what would you hypothesize is the biology that is driving this prognostic difference? Number one. And number two, how would you interact with that biology to actually overcome its effect?
Thank you for that question, and I think it's a really important question. There are, I think, a couple of layers to the prognostic association. The simplest layer is that RCC tumor cells make KIM1. If you have more RCC tumor cells, you have more KIM1. I think that is true to some level, certainly. For example, in the adjuvant setting, certainly people with high circulating KIM1 after surgery clearly have a propensity to recur, probably because they have tumor cells. However, there are a few translational signals that we've been consistently seeing related to tumor biology. And so both in Cosmic 313, but also previously presented by Mark Mahalani in Javelin Renal 101, we have seen that high circulating KIM1 is associated with less angiogenically driven tumors and more kind of myeloid inflamed tumors. And that's been true across multiple trials now in the metastatic setting. And I think this points to kind of a biologic regulatory pathway for KIM1. In the preclinical work for KIM1, which was done actually several years ago and published by Dr. Bonventri's group and by Dr. Quadros' group, we've seen that KIM1, the extracellular domain, is active in autocrine signaling in RCC. And so high circulating KIM1 activates the IL-6 STAT3 pathway, which tends to drive increased HIF-1 alpha expression through transcriptomic regulation. And so I think there is a feedback loop which actually kind of nicely fits in with the known negative prognostic value of CRP and IL-6 in RCC. I think it's all part of the same mechanism. How to target this, I think, is probably a harder question. Whether the decrease in KIM1 is actually a good thing in the setting that certainly by killing the tumor or eliminating the tumor, you're going to decrease your KIM1. Whether that also helps to turn the tumor biology into a more favorable state, I think that hypothesis probably needs to be explored a little bit.
Thanks.
Question for Dr. Ravi. Congratulations on finishing that study. Those studies are, from personal experience, are hard to complete, and I suspect that not doing the SPECT scan actually made it easier to complete because the time commitment that patients have to put into these studies can be significant, and it limits the geographical radius of your study. But I have two questions for you. One is, I didn't see any data on cytopenias, which can be a problem with Pluvicto and other radiopharmaceuticals. So I just wanted to confirm that you did not see any significant cytopenias and that was not limiting. And I'll start with that.
Yeah, you're absolutely right. The first thing when I saw the stats report, when I checked, there was no cytopenias, and I asked the statistician to check, and there were none. So I thought the same thing, and it was surprising, but maybe people attributed to disease progression potentially as well, rather than the drug. And remember, most people only got one cycle, so maybe not that surprising.
And then my second question is, in any of these patients, did they get PSMA PET scans on treatment or at the time of progression? And did you see that there was any change in the PSMA expression?
Yes, so 2 patients had an on-therapy PET scan. And obviously, one patient went on to get 4 more cycles, so that target present, but we're doing some work analyzing the quantitative metrics on those images to see, and as well as the PET PSMA change on the scans to correlate those with what we see on the conventional imaging.
Praful, I've got a follow-up question regarding, actually I think a follow-up question just regarding the expression. And I think with regards to PSMA and RCC, the marker is not actually expressed on the tumor cells per se. It's expressed on the endothelial cells. And by the nature of these tumors being quite vascular, that's why they are hot on PET scan. And I think there was a case report, I'm sure you're very familiar, about washout of the tracer just because it's basically on the endothelial cell. And I wonder if that's why you're not actually seeing the myelosuppression, because the agent's actually getting washed out and it's actually not like on the tumor cell itself. I think looking at those post-treatment images and seeing if there's actually uptake of the tracer, I think like post-imaging or post-treatment specs, I think is going to be super helpful to see if you see the tracer there.
Yeah, unfortunately, we didn't do the SPECT scan.
Yeah.
We didn't do a SPECT CT 24 hours post-therapy, the drug, so we won't have the answer to that question. I think there are a couple of trials ongoing where I think the renal trial, I know Dr. Alvarez was in the audience, I don't know if she can comment if SPECT CTs are being done, but that would be great to see because that would confirm this question of is it hanging around
Right,
or not? Yeah.
right.
simultaneously, like T cell activated, B cell is activated. So what do you think is what's the most dominant effect, and what do you think is the most important for, what's the most important for good immune response?
My answer to that is yes. I think both are going to be critically important. We don't have functional data to say one or the other. At this point, obviously, PD-1 is predicated on unleashing the exhausted T cell state, right? But now there's new evidence coming out of Mary Rad's group, Nature Medicine earlier this year, and there was a great paper in Cancer Cell just last week showing that PD-1 actually, anti-PD-1 unrestrains anti-tumor humoral in the context of hepatocellular carcinoma, and they can identify what the tumor antigens are. So I don't know that you have one without the other. I think we have some, in vivo models we could use to test this, whether it's with a T cell or B cell depletion, or like a UMT mouse where you block the differentiation of pro B cells into B cells and mature B cells to see if there's a dependency on one or the other. That's part of the translational aims that we have in collaboration with the University of Rochester. We have some seed money from both of our philanthropy alliances at the two institutions to test a little bit more of that, specifically in the context of SBRT. But I don't think we necessarily know at this point if one or the other is exclusively or independently factoring into immunotherapy sensitivity phenotype.
Yeah, I have a question for Nick. Number one, a comment. I think your work's very nice. I think one preclinical model by Chuck Crew and John Strode has shown that checkpoint inhibition requires antibody secretion. So they planted syngeneic tumors into a mouse that couldn't secrete antibody, still had B cells, plasma cells. So I think that's you show the differentiation to the later B cells. So that's really nice. My question though is, have you looked at B regulatory cells or markers of that, like IL-35? So from our T cell too. Oh, okay.
So obviously I was reviewer 2, you were reviewer 1. No, but we didn't really show anything, because you mentioned IL-35, looked at things like CD74 that are on the lineage-like markers of these B-regs, either in circulation or in tissue, and at the bulk level and at the single cell transcriptome level, there's no significant changes between conditions. So yes, there's probably a new school population, and we know that B-regs do infiltrate kidney tumors and have some suppressive effects. We don't think we're dramatically changing that population.
Also a question for Nick. I'm an avid user of stereotactic radiation, and I had hoped for a long time that it would enhance immunotherapy in terms of, or in sense of, an abscopal effect. But I've never seen it in my entire career. And the question a little bit is, I do think that immunotherapy, checkpoint inhibition, let's put it that way, can, let's say, enhance the local effect. I think there's some signal for that. But the question is, like, so if it stimulates all these different things, why don't we see this distant abscopal effect? What is in the way? It seems to do something for B cells, sometimes T cells, but we don't see to be able to induce this abscopal effect. Why is that?
It's a loaded question. I don't think I have a perfect answer for it. I'll caveat this with saying I'm neither a radiation biologist nor a radiation oncologist. But I really don't see, particularly in humans, all that much strong evidence supporting the de novo abscopal effect with any radiation modality. I think we oftentimes leverage the term abscopal effect to look at the combinatorial effect of radiation plus the systemic therapy. But in the context of systemic therapies, you really can't have an abscopal effect. And so we really studied the concentrature of the kidney cancer microenvironment with SBRT as a form of immune preconditioning, not as a form of an abscopal effect generator, because we think it primes the immune microenvironment, particularly at the primary tumor site, to be more immunotherapy sensitive, and ultimately that can be disseminated to targeted control of systemic disease as well. I don't know that we're inducing an abscopal effect. We can do shielding experiments in vivo, we can do all of these things. we don't see evidence of it in humans, and I don't think it's really a path that is worth exploring when we can look at combinatorial effects instead.
I've got one more question for Praful. Now you've got this really nice data set of patients with RCC with advanced disease that you've imaged with PSMA PET. I think, you know, understanding the discordance at the lesion level, at the patient level, the intra and interpatient heterogeneity. I think a couple of years ago at this meeting, Kim Rathmell had given a beautiful talk about, you know, RCC and actually the learnings around FDG PET imaging and why we see discordance between FDG PET imaging and potentially FDG PET positive tumors could be more responsive to immunotherapy, and I guess segueing this with the radiation discussion. What are your thoughts on that? What have you seen across the board around the inter and intra-patient heterogeneity with the data set you have?
So much of that work is really just about getting started, because as you saw, we enrolled this trial, just completed enrollment 3 months ago. We just got the first data out, so that work is ongoing. In looking at the scans with Heather JC, who's at nuclear medicine, it's very heterogeneous. There are some patients, all the disease is very avid, but yet that patient didn't respond. In fact, the one patient with stable disease had relatively avid disease. A lot of the patients, it's a little bit avid, and you know, there's some maybe borderline negative disease. The other thing we thought going through the trial is the TKI making a difference? You know, if they're on a TKI right before the PET scan, is that somehow impeding PSMA signals? So we had the patient stop TKI 2-3 weeks before the PET scan. Didn't seem to change much. But really, we sort of, I wouldn't say making it up as we go along, but we were sort of like just exploring and seeing what we found. And my overall sense was, for prostate, we see it. It's like, I can see the PSMA positive disease, right? I can put it on the mitt and I can see it. For these patients, you have to sort of squint for some of them to really see, is it real or not? Is it there or not?
Interesting. I wonder if the patients that had PSMA positive disease, if you, in hindsight, go back and look at their systemic therapies, were they the durable responders on TKI?
I think so. I mean, we only had one stable disease.
Yeah. No, like previous, what they had gotten before.
Yeah, I mean, I think that patient it had relatively indolent disease biology overall from looking through the history.
Awesome, thank you. Any other questions? All right. We're going to move on to the second half, which is going to be more of our translational focus. We've got Zayed Bakuni from MSK now coming to talk to us about mitochondrial DNA mutation phenotype VHL loss to drive non-clear cell RCC.
All right. Well, thank you very much for the organizing committee for inviting me to present today. So I'm going to be talking to you about mitochondrial DNA mutations, and I'll try to convince you first that it's worthwhile to talk about. And I think the thing that got me interested in it is that, you know, metabolism or metabolism-related gene mutations have been something that are pervasive across RCC. Think about FH mutations, SDH mutations, both part of the TCA cycle, but also VHL mutations entirely rewiring cancer cell metabolism, as well as MET and other mutations across RCC subtypes. And so we really know that mutations with metabolism-related genes are important. And what got me interested in mitochondrial DNA mutations is, you know, this is not something that we really think about often, but this paper from Ed Resnick a few years ago had shown that across cancer types, we see an enrichment in truncating mutations within the mitochondrial genome. And across all cancer types, the three that were highly enriched were thyroid, colorectal, and the third one was renal cell carcinoma, particularly in complex 1, the first part of the electron transport chain. And so what is the mitochondrial genome? Not something that I think most oncologists think about most of the time, but it's this small genome, 16,000 base pairs, tiny compared to the nuclear genome, but also very high copy number. So whereas each cell typically has one copy of the one copy from mom, one copy from dad for the nuclear genome, the mitochondrial genome, you have tens of thousands of copies per cell. Depends really on the number of mitochondria you have in a cell. For a kidney cell, normal kidney, you can have thousands of mitochondria and therefore tens of thousands of mitochondrial DNA copies. It's a circular genome, and its entire function is to encode for parts of the electron transport chain, which is responsible for oxidative phosphorylation, the primary process by which cells generate ATP. And the mutations really accumulate in this first part I told you about, complex 1. Before diving into data, the last concept I'll introduce is that because of the very high copy number of the genome, the concept of heteroplasmy is very important, meaning that if you have one mutation in one copy of the genome, doesn't really matter to the cell, it's not going to do anything. But if you accumulate mutations or multiple mutations in these genomes, or one mutation that takes over most of the mitochondrial DNA in a given cell, then you reach this biochemical threshold. We know this from the inherited mitochondrial DNA literature for inherited mitochondrial diseases. And at that point, these mutations lead to a phenotype. And so diving into some data, this is a co-mutation plot that's a bit busy, but I'll walk you through it, about the landscape mitochondrial DNA mutations in RCC. This is leveraging about 700 patients from MSK Impact at Memorial, where we used off-target reads to call mitochondrial DNA mutations across subtypes of RCC. So at the top, I'm showing you the annotations for the subtypes of RCC: clear cell, papillary, chromophobe, unclassified, and then oncocytomas. And then on the left-hand side, I'm showing you the nuclear mutations that have been shown to be drivers in each of these subtypes, primarily for clear cell, papillary, chromophobe, based on TCGA. And then I'm showing you the nuclear mutations for these, nothing new. You know, we kind of know all these 3P loss, VHL mutations, et cetera, for clear cell, chromophobe, very few, papillary, very few, et cetera. And then here I'm showing you the heteroplasmy of the mitochondrial DNA mutations, particularly truncating mitochondrial DNA mutations. So these are functionally relevant. And you can see that heteroplasmy is pretty high, up to 100% in many of these tumors. The same mutation accumulating in tens of thousands per cell across each cell. So clearly very strong clonal selection that's occurring for these mitochondrial DNA mutations, or presumably clonal selection. And we see this across subtypes, in clear cell, in papillary, in chromophobe. I think in chromophobe it's been recognized, in oncocytoma it's been recognized, but I don't think it's been recognized in these other tumors that we see this frequency of mitochondrial DNA mutations. Next question we asked is, among the tumors that we don't identify nuclear drivers for, so we don't see VHL mutations, we don't see 3P loss in clear cell, we don't see MET mutations in papillary, et cetera, in that subset that are quote-unquote driverless in each of the subtypes, what proportion of these have mitochondrial DNA mutations at a reasonable heteroplasmy threshold? And we see up to 20% of clear cells that are enriched in mitochondrial DNA mutations among driverless clear cells. Among chromophobes and papillaries, about 30 or 40%, oncocytoma, 60%, and then unclassified up to 50% or so. And crucially, among the unclassified, if you divide them into ones with nuclear drivers and those without nuclear drivers, the ones without nuclear drivers are heavily enriched in mitochondrial DNA mutations, indicating that these could be really driving a significant subset of unclassified RCC tumors. Not only that, but they also behave differently clinically. The ones that have a high burden of mitochondrial DNA mutations have a significantly different overall survival, behaving more like an oncocytic-like tumor as opposed to typical unclassified. But we wanted to understand this functionally, so it's been very challenging to study mitochondrial DNA mutations, and the reason for that is engineering mitochondrial DNA mutations and generating isogenic systems has been difficult. A novel technology that was developed here in Boston called the DDCBE now allows us to introduce in situ mutations inside mitochondrial DNA. This gets over the fact that you can't shuttle nucleic acids into the mitochondria and uses a tail-based approach instead with a cytosine deaminase enzyme. So using that, we've generated a panel of isogenic cell line models, including based on ACHN, 7860, and HEC293T cell lines, that are all isogenic with each other, but with the only difference being the extent of the heteroplasm, which I'm showing you here. And using these systems, we've been able to ask what these mitochondrial DNA mutations do in a kidney cancer context. And the first thing we notice is that these cells stop using oxygen almost entirely. This is a standard seahorse assay. These cells are decreasing the amount of oxygen consumption when they're at high enough heteroplasmy, indicating that these mutations are functionally relevant. And at 76% heteroplasmy here, these cells stop using oxygen almost entirely. They grow normally in a glucose-enriched condition, but if you put them in galactose, with increasing heteroplasmy, they divide less and less and eventually die off. And that is because these cells are entirely dependent on glycolysis and are unable to engage in OXPHOS for the ATP needs. Further, they increase their glucose consumption, can measure it with the amount of heteroplasmy, and they increase their lactate production, can measure it with the extent of heteroplasmy. I think crucially, this is mimicking largely what we see with VHL knockout. So if you knock out VHL in the cell line, you see the same effect. You see a decrease in oxygen consumption, and you see an increase in glucose consumption and lactate production. Suggesting that a lot of the metabolic phenotypes that we're seeing with mitochondrial DNA mutations are at least in part phenocopying what we see with VHL mutations. We wanted to further understand what this heteroplasmy is doing to cells. So an experiment we did is we took a pooled cell line system where we had a range of heteroplasmies, and then we used a technology called DogmaSeq, which allows us to read out transcriptomics, chromatin accessibility, and mtDNA genotype at the single cell level. Because we had a pretty wide single cell distribution of heteroplasmy, even though the bulk heteroplasmy was 60%, we had a very wide single-cell heterogeneity and heteroplasmy, we could ask what the effect of heteroplasmy was in the isogenic system on transcriptional state and chromatin accessibility. What we first found is that these cells clustered into 2 different clusters, and they differed significantly by extent of heteroplasmy, indicating that heteroplasmy was driving both the transcriptional as well as the chromatin state of cells. And the cells were enriched in transcriptional signature that was very stem-like, particularly for things like OCT4 target genes and whatnot, in the high heteroplasmy subset. So that indicated that these cells that are high heteroplasmy are less differentiated, and this could be one of the oncogenic mechanisms. To try to start understanding the mechanism by which this might be occurring, we performed LCMS and GC mass spec on these cell line models. And what we found is that in VHL knockout, and this has been recognized before, you see an increase in 2-hydroxyglutarate and a decrease in alpha-ketoglutarate. And we also see this with pharmacologic inhibition of complex 1, and we also see this with increasing amounts of heteroplasmy. So why am I telling you about 2-hydroxyglutarate and alpha-ketoglutarate in the context of a stem-like transcriptional program? Well, it's because alpha-ketoglutarate is a substrate for TET and KDM enzymes. It's responsible for demethylation of histones and DNA, and it's inhibited by 2-hydroxyglutarate through competitive inhibition. You might recall that IDH mutations typically lead to D2HE, and that's the oncogenic mechanism in a lot of IDH mutant tumors. But there's also work from the Thompson lab has previously established that for both the D and the L enantiomer of 2HE, the L enantiomer, which is pretty much the same thing, but just slightly different configuration of what the hydroxyl group is on the carbon, are generated by LDHA and MDH2 without any IDH mutations. And we confirmed that this is the mechanism here that's presumably happening, which is that the L enantiomer of 2HE is the one that's driving this increase in 2-hydroxyglutarate. So overall, we think that this might be a mechanism by which these mitochondrial DNA mutations are playing an oncogenic role. My slides are stuck. I was going to say that we have a poster, I think it's poster 103, here we go, that's looking at these mitochondrial DNA mutations in situ. We designed a novel assay to do this. It was in large part done with Rachel Sachs, so please take a look at that. It's a virtual poster. With that, I'd like to thank the members of the Thompson lab, the Resnick lab, particularly Rachel Sachs, who's here in the crowd, and all the group of RCC at MSK, particularly Ari Hakimi and his lab, and the many excellent clinicians that I work with, and all our funding sources, including the DoD. Thank you very much.
Next, we have Dr. Rishabh Raut from Yale School of Medicine talking about single-cell transcriptomic investigation of RCC, revealing tissue-resident memory-exhausted CD8-positive T-cell signature with ICPI inhibition.
Hello, my name is Rishabh Raut, and I am at the David Braun Lab at Yale. So I've been told that you should all be pretty familiar with the cancer immunity cycle, so I'll be using this to contextualize my question. So basically, to skip to the very end, there are cases where, assuming that you have tumor-specific T cells and that they've sufficiently infiltrated the tumor, you might still have cases where cancer cells aren't recognized and aren't killed. And in this case, traditionally, it would be expected that T cells must be phenotypically dysfunctional in some way. And in the case of CD8 T cells, this can present itself in the form of exhausted T cells. So in the end, the question that we really want to hope to answer is, why do highly CD8 positive T cell infiltrated tumors not respond to immune checkpoint inhibitors? So before we begin, a quick overview of the data. So this is derived from a large-scale cohort, which has 70 kidney cancer patients. And this cohort is defined by heterogeneity, including a mixture of kidney cancer histologies, immunotherapy treatments, treatment exposures, and responses. The samples that this research focuses on are basically the clear cell samples that were treated with any form of immune checkpoint inhibitor. And this presentation focuses on the analysis of the single cell data. Over 400,000 cells are sequenced, and they capture a variety of lymphoid, myeloid, epithelial, and tumor populations. And as mentioned earlier, we are primarily interested in the CD8 plus T cells. This population of cells was further computationally clustered, and out of these clustered, those with exhausted T cells were identified through markers including TOX, TIM3, and PD-1. Following this, tumor and viral-specific T cells were identified through the expression of known signatures. As the matching UMAPs depict, the majority of exhausted T cells do have tumor specificity. When checking the abundance of T cell specificity in samples that were responders as opposed to non-responders, the proportion of tumor-specific T cells in non-responders was significantly lowered, which prompts further exploration to understand the makeup of some specific T cells that lack tumor specificity. The exhausted CD8 population was then put through another dimensionality reduction technique called NMF, which identified 4 programs, and each had their own representative genes that were correlated to a specific biological phenomenon. These programs were innate-like and tissue-resident exhausted T cells, those that expressed exhaustion and activation markers, a stress response program, and immediate early genes. We decided to see if any of these programs had a difference in abundance between samples that responded and didn't respond, and the program that displayed tissue residency markers ended up being significantly more present in non-responding samples. Furthermore, we stratified these groups of samples into those with high and low percentages of tumor-specific T cells, and within those with the T cells with higher percentage of tumor-specific T cells, the significance grew. And on the other hand, there was no significant difference in the tissue residency program's abundance within low tumor-specific samples. So this suggests that the program not only correlates to ICI resistance, but that it also expresses itself most in tumor-specific CD8 T cells, which may mean that it's most directly related to the lack of their function. To understand the tissue resident program further, we decided to explore the external bulk cohorts from immunotherapy studies. And these cohort arms were treated with either ICI therapy or combination ICI therapy. We combined all of these arms to allow us to observe the effect with the greatest power. And to translate our tissue residency program to bulk data, we derived a gene signature that was done so through looking at top expressed genes and differential gene expression between this program and the other programs. When looking at the expression of this signature, it was significantly higher in patients with progressive disease as opposed to those with complete or partial response. And that basically supported the claim that this resident memory phenotype may be related to the anti-tumor failure. Our next steps were to explore if there were any specific markers that predict the occurrence of our tissue residency phenotype. And this was conducted through another computational method called NicheNet, which is given a sender group of cells and receiver group of cells and a model of cell-cell communication and proposes a list of ligand receptor pairs. In this case, we started with a broad group of senders, including macrophages, tumor cells, cancer-associated fibroblasts, and Tregs, and our receiver was our resident memory exhausted CD8 T cells. Out of the suggested ligands, TGF-beta1 stood out consistently as it interacted with important receiver markers, which included CD69, IL-7R, and interferon gamma. We decided to further explore the relationship between TGF-beta1, tissue residency, and ICI resistance. For the next set of analyses, we split our samples into those that expressed higher and lower proportions of the tissue residency phenotype, and I'll shorten this to TAX-RM. We see that TGF-beta1 itself was significantly highly expressed in samples that had high TAX-RM, and we also looked at the expression of SMAD, which is one of the primary factors linked to the TGF-beta pathways, and once again, it was more highly expressed in samples that had high TAX-RM. To corroborate these findings experimentally, we cultured naive CD8 T cells under hypoxia or normoxia, and then either treated or didn't treat them with TGF-beta1. This work was primarily conducted by Seoki Kishima. Under these conditions, we see that under hypoxia and TGF-beta1 stimulation, CD69 and CD103 are both most highly expressed, which are key markers of tissue residency. And even under normoxic conditions, TGF-beta1 induces higher levels of these markers. Under these same conditions, both PD1 and TIM3 are most significantly highly expressed, which confirm that these CD8 T cells are also reaching the state of exhaustion. When comparing interferon gamma and TNF-alpha concentrations between hypoxic T cells that were untreated and then treated with TGF-beta1, both of these concentrations went down, which suggests that cytotoxicity went down and the T cells became more dysfunctional. And finally, the percentage of specific lyses of tumor cells was significantly reduced upon treatment with TGF-beta1. And the combination of these experimental analyses suggests that TGF-beta1 is linked to expression of the resident memory phenotype within exhausted T cells. Our research suggests that resident memory T cells fit this dysfunctional phenotype exactly, and that TGF-beta1 could be the main markers along pathways that result in this phenotype, and further research interaction with other cell types that affect resident memory T cells could help us understand the kidney microenvironment to a greater degree, and also come closer to making other CD8-based immunotherapies more effective to treating clear cell RCC. I'd like to thank my mentors, David Braun and Saki Kashima, as well as a fellow member of my lab, Xiaoshen Yi. Thank you as well to my collaborators, funding sources, and of course the patients and their families. Thank you.
Thank you so much. Wonderful. Our final speaker will be Dr. Carrie Runcie from Columbia University, talking on CD8 positive T cells and clinical outcomes from the cytoreductive nephrectomy in kidney cancer plus immunotherapy, basically cytokick trial. Thank you.
Thanks, Rana, and thank you to KCRS for the opportunity to present this data, clinical outcomes and mechanistic correlates from the phase 2 trial of cytoreductive surgery in kidney cancer plus immunotherapy, nivolumab, and targeted kinase inhibition, cabozantinib. Although we've made remarkable strides in the therapeutic treatment of metastatic clear cell kidney cancer, still about 10 to 15% of patients experience durable responses to our current first-line regimens. We have limited data about the patients who respond and don't respond to current IO and TKI regimens, including cabozantinib and nivolumab. Prior single-cell RNA sequencing data from David Braun, Ari Hakimi, and others have begun to characterize the immune microenvironment post-immunotherapy, and paying particular attention to the T cell and the myeloid cell compartment, and assessing the response to treatment, correlating this with treatment outcomes. This is a cytokick clinical trial design. This is a phase 2 open label single arms trial of 38 subjects who enrolled with de novo metastatic clear cell kidney cancer. They received 12 weeks of systemic treatment with cabozantinib and nivolumab prior to cytoreductive nephrectomy. Post-operatively, they resumed systemic treatment. The primary endpoint was complete response rate, and we collected fresh frozen tumor specimens pre-treatment and from the nephrectomy specimens. We performed single nucleus RNA sequencing and TCL receptor sequencing on some of these pre-treatment and post-treatment samples, which included 3 pairs of pre- and post-treatment samples. We also have FFPE and PBMCs and plasma, which we plan for further analyses. Here are the baseline patient characteristics. There's 38 subjects. The median age was 64. Majority of the patients were under 65. As you would expect, it's male predominant. 74% of patients had intermediate risk disease, and the majority of patients had metastases to lungs and lymph nodes. Here's a swimmer's plot and highlighting the clinical responses. At a median follow-up of 18 months, the overall response rate was 59%. We had 4 complete responses, and there are 7 patients that remain active on treatment. At the top of the swimmer's plots, I didn't get to highlight, but 2 of those patients discontinued study treatment. They had near CRs, and after 30 months of follow-up, they remain with durable responses. Sorry. So we performed a single nucleus RNA sequencing on all samples, and you can see in the UMAP there that we were able to separate the cells into malignant and non-malignant cells and into the different compartments. On the right, we looked at the specific immune cell subpopulations and correlated it with treatment responses. In the subjects with progressive disease, you can see that there were a higher proportion of macrophages in this population. And looking at the paired pre- and post-treatment samples with an N of 3, you can see that post-treatment with cabozantinib and nivolumab, there was an expansion of the CD8 positive T cell compartment and a decreased proportion of the tumor-associated macrophages. In terms of the T cell compartment, we identified 10 subpopulations encompassing the CD8 positive T cells and the CD4 positive T cells. And looking at the pre and post-treatment paired samples, we see that there's a higher abundance of the CD8 positive exhausted T cells in pre-treatment samples, and a higher abundance, and this shifts to CD8 positive tissue resident exhausted and terminally exhausted T cells in the post-treatment samples. Leveraging some of the T cell receptor data in paired samples in patients that had stable disease, we noticed an expansion of the CD8 positive exhausted T cells to CD8 positive tissue resident exhausted T cells. And some of these CD8 tissue resident exhausted T cells have been described to be associated with improved PFS previously in subjects that received combination IO plus TKI. Looking at the treatment response associated with the responders and non-responders, we see that there is a higher proportion of these CD8 positive terminally exhausted T cells in the CD4 positive memory cells in the patients who had a response. Now shifting to the myeloid compartment, in the myeloid compartment we identified 7 subpopulations of macrophages, including previously described SPPP1 and HLA high macrophages and non-responders. You can see the Mu map on the left of all these macrophage subtypes, and on the right, when we looked at the change in the macrophage population with response in regards to the responders and the non-responders, we see a higher population of the SPP1 and HLA high macrophages and non-responders. And looking at a myeloid, a macrophage trajectory analysis, looking at a differentiation of the myeloids in non-responders versus responders, we also note that the macrophages differentiate along a trajectory from low to high HLA expression, and the responders had a higher HLA expression with response to cabozantinib and nivolumab. We also did NMF analysis to identify multiple transcriptional programs that correlated with treatment response. And here's the heat map and how showing all the samples and how it correlates with pre and post-treatment samples as well as the treatment response. And here we look at the differential treatment responses along an axis of the malignant AMHC1 presentation and proangiogenesis programs, and comparing all samples to the unpaired samples of the responders and the non-responders. You can see there's an enrichment pattern in the subjects that had partial response or stable disease. They had a robust MHC1 presentation and negative MAP kinase regulation. In the subjects that had progressive disease, there was sustained angiogenesis and MAP kinase activity. Now focusing on the paired samples in which the subjects had stable disease and a partial response, we noted at baseline that there was a hypoxia response in the pretreatment stable disease samples. In stable disease, we also noted that there was robust MHC1 presentation, and in the partial responders, we noted that there was a negative DNA damage response regulation. So our working model for differential clear cell kidney cancer response with regards to the combination of cabozantinib and nivolumab. In complete and partial responders, we noted that there was robust MHC1 presentation, and in the presence of these of PD-1 blockade, we noted an expansion of the exhausted CD8 T cells to the terminally exhausted T cells. And at the same time, cabozantinib negatively regulated the angiogenesis MAP kinase signaling pathway. In stable disease, we noticed that there was sustained, there was still robust MHC1 presentation, but we also noted that regardless of the presence of cabozantinib, that there was still sustained angiogenesis and MAP kinase signaling. And in progressive disease, there was an abundance of the tumor-associated macrophages, SPP1 and HLA-C1q tumor-associated macrophages, and regardless of the cabozantinib, that there was no effect on the angiogenesis signaling and pathways. Conclusions: Cytokit demonstrates safety and feasibility of cytoreductive nephrectomy in our current treatment era. single nucleus RNA sequencing, T-cell receptor sequencing, and transcriptional programs demonstrate changes in the T-cell and myeloid compartment that correlate with treatment response, and we plan for further correlative analyses to validate these findings, and that may suggest strategies to overcome therapeutic resistance in our non-responders. Thank you.
All right. That concludes our talks, and now we're going to open it up for questions. We've got 20 minutes of panel discussion for the latter speakers.
I forgot to say thank you to all these people. Huge shout out to Calvin Park, who's applied for oncology fellowship and led a lot of this this summer.
Thank you, Carrie. You've got the mic. Go for it.
Okay. I have a question for Ziad, actually. So first, a comment. I was not the reviewer. Now the question. So basically, a couple of ideas over here. So one is when you're doing your mutation profiling, how to distinguish whether the mutation is in the mitochondria of the tumor cells versus stromal cells. You know, recently we have started seeing that there's transfer occurring in between the tumors and the stroma. So how are you thinking about the biology that might carry between the two compartments over here?
Yeah, I mean, that's a great question. There's a lot of literature now about like transfers of mitochondria, et cetera. We have, I'll encourage you to look at the poster we have that's separately. So there we've designed a custom assay to look at mitochondrial DNA mutations in situ, and we see that they accumulate almost exclusively in tumor cells.
Okay.
And we are, and so I think the signal is almost entirely coming from tumor cells, which I think makes it even more impressively heteroplasmic per se, because it is slightly underestimating the heteroplasmy we're seeing in tumor cells, especially for immune-enriched and stroma-enriched tumors.
So that was the perfect segue for my second question. So when you introduce the heteroplasmy in your cell line model systems, two parts to that. One is that once introduced, partitioning is occurring with every division, and are the mitochondria now maintaining, is heteroplasmy being stably maintained in the culture for long periods of time? And related to the biology that you said, if mitochondrial truncating mutations are phenocopying VHL loss, have you tried to do the same experiment in the VHL proficient lines? Because the picture that I think it went a little fast, but I thought it was mostly 7860, A498s, all VHL deficient lines that the experiment was.
No, the primary seahorse assay, a lot of the experiments are primarily ACHN cell lines, the VHL wild type. So those are the main ones, and the seahorse assay, the glucose consumption lactate, all that is in ACHN, so VHL proficient. In terms of maintenance, I've looked at maintenance for, I think the most I've checked is probably 9 passages or so. And at 9 passages, there's it's pretty stable. I do maintain them with excess pyruvate and uridine to maintain the heteroplasmy. I think if you culture them in glucose depleted or pyruvate depleted, conditions like that, you lose the heteroplasmy. But in enriched media conditions, they maintain heteroplasmy.
Okay. Go ahead, yeah.
First of all, great talks all around, really beautiful presentations. But a question for Rishab, TGF-beta signaling and its implication in resistance to immunotherapy has been around in other diseases for quite some time, to the degree that a number of agents interacting with that biology have been developed, have been tested, and so far have been found to be negative. Is that because we've been looking in the wrong tumor type, and RCC is the tumor type where this should be looked at? Is it because the agents that have been used are wrong, or is it because this biology is an artifact and isn't actually truly actionable?
Yes, thank you. Thank you for the question. And yes, that's true. There have definitely been a wide variety of agents used, and most of them have been pretty ineffective. But that's something that we are looking into, and I do believe that specifically in kidney cancer, anti-TGF-beta1 would be something that would be interesting to look at.
Ziad, this is just looking at your seahorse plots, it looks like your cells might actually be dependent on fatty acid oxidation. Have you looked at seahorse using the palmitate assay? And number 2, have you seen any increased lipid droplets or increased mitochondria as a result of fatty acid oxidation dependence?
Yeah, that's a very, very good question. I haven't looked at the palmitate assay. I think it's certainly possible that they're more dependent on fatty acid oxidation, and that I have not even looked at lipid droplet in this context as well, but definitely something that we're planning on doing.
Do you notice that the cells with heteroplasmy, the cell media turns yellow faster than their wild type?
Absolutely. It's like very stark. And I mean, we quantified that with the YSI assay I showed, but in terms of lactate, but definitely gets much yellower, much quicker at similar cell densities.
It sounds like you got your answer.
Say that again.
Sounds like you got your answer on fatty acid oxidation, because that acidification comes from a lot of the fatty acids, and that's what turns the media yellow.
Yeah, it could also be just lactate, right, as well, either from aerobic glycolysis.
Zayed, I have a question.
Question for Ziad. Sorry.
Oh, go ahead. Oh, Kelly, you're reading my mind.
I don't see you, Rana, but I hear you. So Ziad, my question, so this may just stem from limited knowledge of mitochondrial genetics, but does 2-HG have a similar impact on mitochondrial nucleoids as it does on histones? And if so, is it possible that the finding of elevated 2-HG preceded the heteroplasmy that you observed?
I think it's possible, but we see it in ice. So you're saying that as a result of 2-HG, we're seeing heteroplasmy develop? Is that the question?
Yes.
Yeah, I mean, I think we did this in an isogenic system where once we introduce the heteroplasmy, we see the 2-HG elevation. So I think the causality is that way. I think the mechanism, which we haven't formally worked out, but I think is yet, but I think I have some correlative evidence to show that it's probably through NADH accumulation without the stress of these cells leading to the increase in 2-HG. So I think that's probably the mechanism, and it results from the heteroplasmy.
And then is there consequently any positive feedback as a result?
That's a great question. I personally don't know that much about, and I don't think the field knows that much about transcriptional regulation of mitochondrial DNA. I don't think it definitely doesn't follow the same rules as the nuclear DNA. We also have not fractionated and looked at where the 2-HG accumulates in the cells. But I don't know if there would be an effect on the mitochondrial DNA. It's a great question.
Zayed, I have a follow-up, and Kelly is one of the PIs, and UHN, another PI of 2 IITs that are testing belzutifan for non-clear cell RCC, one that's predicated on patients having a VHL mutation. I think, Kelly, if I'm not mistaken, your trial is not necessarily using that genomic criteria for entry. Do you think that this is therapeutically targetable? Like, do you think that this could be targeted with a HIF2 alpha inhibitor, and there's rationale for doing that here?
Yeah, it's a great question that I'm trying to test currently, actually, but I don't know that HIF is necessarily going to be the best way to target them. I don't know that for sure yet. I think it would be great if it is, but I think there are some other potential vulnerabilities and agents that are being developed that we are actively investigating. I think anything that would in any way turn down their ability to engage in glycolysis would be, for instance, an obvious way to target this. But yeah, work in progress.
Okay. Other questions? Anybody? Tony.
Question, Dr. Ramsey. The 58% response rate is a bit high for cabo-nivo with kidney in place. Did that exclude the kidney in place or include, or it's a bit higher than what we reported in the metastatic setting?
That's overall response with after the kidney taken out.
After the kidney taken out, okay.
Anybody else? Oh, yeah, go ahead, Don. Pass the mic to Don.
I'll just say it loud. Zia, is there any evidence to DNA repair machinery in mitochondria? They have their own basic system repair, for instance, that's proportional to this rate of mutation in the landscape of kidney cancer.
So if I understand the question correctly, it's about the mechanism for the
DNA repair for mitochondrial DNA.
Yes, I think the polymerase and the DNA repair in mitochondria is just it's less well developed than nuclear DNA. So the polymerase is more error prone, and the repair is inferior to nuclear DNA. So all the mutations that we see are actually, I mean, the recurrent mutations are all in whole polymeric tracks. They occur in sequences of A, C's, G's, etc. And so the mechanism appears to be that the polymerase just slips and adds an A, adds a G, and so that's a frame shift mechanism in whole polymeric sequences. So that is the presumed mechanism, but I think that is how an initial mutation would occur, but how it would then involve all 10,000, 100,000 copies for each individual cell in each of the cells of the tumor, that is presumably through clonal selection and not through, because it's the same mutation that is occurring across 10,000 genomes within each cell of the tumor.
Okay. Any other questions? Going once, twice? All right, thank you so much to our fantastic oral presenters. You all did a fantastic job.